master's degree and MD degree in clinical pathology by Dr. Wassefy, lecturer of clinical pathology. We are first going to identify a status of immunodeficiency, by which is it may be a primary case or secondary case. The primary is born with the pathology, but the secondary usually an immune defect resulted by other non-immunological diseases like rhinostomal disease or drugs like phenytoin or HIV. Usually the child is presented with recurrent infection, two major or one major and recurrent minor, usually with an unusual organism like aspergillus or pneumocystitis, and also unusual sites like liver abscesses, osteomyelitis, chronic infections like sinusitis, structural damages like bronchiectasis, and other associated autoimmune diseases. We are going to depend and pay attention to the failure to thrive in this person and also the structural damage associated from the recurrent infection. For example, in the physical examination, if you notice on absent tonsils, this may be a B-cell defect. Absent lymph nodes is associated with the combined T and B defect. Lymph node hyperplasia is associated with common variable immune deficiency or chronic granulomatous diseases. The absent BCG scar is associated with T cell defect. The delayed separation of umbilicus stump is mainly related to leukocyte adhesion defect. You are going to first must ensure that the use of facilities wisely, by which you target investigations to differential diagnosis and ensure that the basic tests are done before the exotic test. The simple and easy one to use first is the complete blood count. It will give you an idea about the total white PCs count and neutrophil and lymphocytes. Also, you may use a blood film from the same specimen to ensure the quality of the cells, but you can't, by this complete blood count, you cannot differentiate between B and T lymphocytes. So in this situation, you are going to use the flow cytometry. About the B-cell function, it's mainly presented if it was defective with recurrent bacterial osteomyelitis pneumonia are common in hypogammaglobulinemia. Also, the examples of B-cell immunodeficiencies related to protons X-linked agammaglobulinemia, common variable immunodeficiency, transient hypogammaglobulinemia of infancy. Also, selective immunoglobulin A deficiency or selective immunoglobulin G subclasses may be presented. Also, the immunoglobulin deficiency with increased immunoglobulin M. We are going to discuss in brief shortly. As regards the X-linked immunoglobulinemia, it's an X-linked and mainly related to early maturation of lymphocyte failure. It affects male, and usually few or more B cells are present in the blood and very small lymph nodes and tonsils. No immunoglobulin are present. Also, small amount of immunoglobulin G may present at early age, but recurrent pathogenic infection is a marker. As regards both immunoglobulin A or immunoglobulin G subclasses deficiency, the most common one is immunoglobulin A deficiency. The persons here can develop immune complexes diseases, and also about 20% lack immunoglobulin G2 and G4. They are susceptible to biogenic infections and usually a problem in failure internal differentiation of B cell. The one with increased immunoglobulin M, we must notice that during the process of maturation of B cell, it first forms immunoglobulin M, then a process of cross switch occurs to transform this immunoglobulin M into immunoglobulin G and other forms. So this person is characterized by having immunoglobulin A and G deficiency. He can produce immunoglobulin M in large quantity, about more than 200 milligram per deci of polyclonal immunoglobulin M. He is susceptible to biogenic infections. Also, the treatment is usually with intravenous gandaglobulin. Also, formations of immunoglobulin M to neutrophils, platelet, and other blood component due to inability of B cells to isotype switching. The immunoglobulin M, about 70% of them is X-linked, and also due to the CD40 ligand gene mutation, and also some of them is an autosomal recessive due to defect in the enzyme, B-cell enzyme called cytidine deaminase. The common variable one is a problem in acquired agammaglobulinemia in the second and the third decade of life following viral infection, characterized by recurrent pathogenic infections. Usually the person is having B cell, but they are not functioning. B cells also are defective in their function as they failed to receive the help of the T cell. Hypogammaglobulinemia of infancy, usually related to delay in the immunoglobulin G synthesis, approximately up to 36 months. The infant can synthesize his own immunoglobulin G, but is having normal B lymphocytes, and this is mainly due to the lack of T cell help for the B cell. What about these lab tests used? The serum immunoglobulins like immunoglobulin G or immunoglobulin M Also, serum and urine electrophoresis may be done. Antibacterial, antiviral antibodies, immunization response also may be used using the flow cytometer CDs 19, 20, 22 found on B cell. Also, the in vitro studies related to using of mitogens like buckwheat mitogens, which stimulates the antibody production by the B cell. Here is the hierarchy how to deal with a case of B cell deficiency. Are going at first, he is going to be presented with recurrent bacterial infections. You will suspect a B cell defect, so are going to ask him to use immunoglobulin immunoglobulin level. If they are normal, you are going to ask for the subclasses of immunoglobulin G. If they are normal, you are going to ask for antibody response to polysaccharides and proteolytic antigens. If they are normal, that's fine, but if they were abnormal, or if the immunoglobulin G subclasses were abnormal, or even from the start, if the immunoglobulin levels were abnormal, the familial histories and the T and B cell phenotype, also the karyotype and genetic study will be asked. What about the T cell function? T cell is responsible for fighting fungal and protozoal and viral infections, so this person is having a defect in the fighting of those three types of organisms, characterized by pneumonia, chronic infections of skin and mucous membranes, for example, Dye-George syndrome and chronic mucocutaneous candidiasis. The Dye-George is a T cell immunodeficiency, congenital thymic aplasia and hypoplasia associated with hypoparathyroidism, congenital heart disease, and fish-shaped mouth. The combined effect of T and B cells like ataxia telangiectasia, it's ataxia, so cerebellar manifestations and incoordination of movement is presented. Telangiectasia, dilated blood vessels over the face are presented to T cell defect in their function. The function is reduced and the count is reduced, and also B cell number and immunoglobulin concentrations are normal to low. The immunoglobulin G is reduced, the immunoglobulin A also is reduced, high incidence of malignancy, and the major defect is in TCR and BCR, T cell receptor and B cell receptor at chromosome 14. As regards with Dye-George syndrome associated with normal T cell number but reduced function, immunoglobulin M concentration is reduced but G is nearly normal. Both immunoglobulin A and E level are elevated. It affects boys and associated with severe eczema, and also they respond poorly to polysaccharides antigens and are prone to pyogenic infection. What are the tests used? You are going to use the T cell number and surface phenotype by the flow cytometer. You will ask for CD2, 3, 4, 8, 7, TCR, alpha, beta, or gamma delta, CD40, 40 ligand, MHC. Also, you may use the T cell proliferation to antigen or mitogens like PHA or PMA. You are going to use also T cell cytokine productions, which is immunoglobulin, which is interleukin 2. I'm sorry. Also, in vivo studies like delay type hypersensitivity testing is used. How to diagnose a T cell? This is the hierarchy: recurrent opportunistic infection and or severe viral infection, diarrhea, failure to thrive, autoimmune diseases, B cell proliferation. Just ask for the lymphocyte count and immunoglobulin level. If they were normal, ask for T and B cell phenotype or antibody response, in vitro T cell response. If it was normal, it's okay. If it was abnormal or from the start, if the lymphocyte count and immunoglobulin level were abnormal, you are going to use the T and B phenotype to assess the severe combined immune deficiency or a combined immune deficiency diagnosis. What about the defect in phagocytes? It may be in the form of cyclic neutropenia, by which low number of circulating neutrophils occurs every 3 weeks. He is prone to infection, and usually the defect is in poor regulation of neutrophil production. The chronic granulomatous disease is characterized by defective function of the neutrophil. The person is presented with recurrent lymphadenopathy, splenomegaly, hepatosplenomegaly, and chronic drainage of lymph nodes. In the majority, a defect in NADPH oxidase that participate in the phagocytic burst formation. Also, leukocyte adhesion deficiency, a defect in the complement receptor or in the CD11, ABC, or CD18 or CD15 is presented. Usually, this person is characterized by a problem in the diabetes of neutrophil, attraction of neutrophil to the site of infection, and this YouTube video will help you in understanding what's diabetes and the movement of neutrophil and the margination to enter to the site of inflammation. The celiac is a syndrome with slower rate of intracellular killing, inability to form phagocytosome, and the proteinase deficiency. Recital burst is normal, usually is associated with natural killer cell defect, platelet, and neurological disorder. As we said before, you may use flow cytometer to estimate the neutrophil markers, CD 11 and 18 and 15. Also, using neutrophil markers like PMA. Also, respiratory oxidative burst is ensured by the flow cytometer. Also, a common test is the nitroglutazolone test, which is quantitative and qualitative to assess the phagocytic function of the bacterial phagolysosome, and the relevant organisms should be selected. In case of severe combined immune deficiency, this person is suffering from both T and B cell defect in their function and their quality of functioning. So it's quantitative and qualitative. It may be X-linked or autosomal. Usually common bacterial and viral and mycotic infections are presented. It may be X-linked, had effect in gamma chain of interleukin 2, or it may be autosomal, which had effect in adenosine deaminase enzyme or purine nucleoside phosphorylase gene defect, leading to toxicity to lymphoid stem cell. In this situation, we are not going to use both tests, using for both T and B cell and immunoglobulin measurement, and the only solution in this situation is bone marrow transplantation or umbilical cord transplantation. Here is the complement assay, the one with the problem in complement itself or in the complement regulatory protein. In both situations, he is going to suffer from recurrent incisional infections, and you are going just to measure the total component of the complement assay, specific complement measurement, or using the hemolytic assay for the function of the complement. The exotic tests that we said before, you must not begin with are the cytogenetics, and also the PCR and TCR rearrangement, clonality, and X-linked gene studies is used. Also, you may use some of tests to assess the autoimmunity toward the blood cells or thyroid antibodies. Also, you must exclude secondary causes like renal disease or drugs, or dysplasia, or using CDs, using ultrasound or CTs, computerized tomography, means scanning يعني, أو lung function also may be used. Thank you for your